webinar starting. Thank you so much. Dr. Joseph, the floor is yours.
Thank you, Judith. Dear colleagues, friends, and partners, good morning, good afternoon, and good evening to you. I know you are joining today from many different countries and time zones. Thank you all for being here. Welcome to today's webinar. It's my pleasure to welcome you on behalf of WHO Global NTD Program. You will see that we are no longer calling it WHO Department, but it's a Global NTD Program because this program belongs to countries, communities, and to all partners. It's really important to reposition it. And we are gathering today to discuss a very important piece of work whose aim is to support countries in their effort to mobilize resources to achieve the NTD program targets. Lack of funding was identified as the key challenge across all the 20 plus NTDs identified in the roadmap. So this challenge is even greater in NTD endemic countries, facing the prospect of increased restriction of budget for developing the evidence and momentum we need for successful advocacy and concrete funding for NTD intervention is absolutely crucial to our work and must be at the forefront of our thinking. Now, 2 years into the term of the new roadmap, the need for clear funding priorities and figures has become even more pressing. That is why I have recently announced the formation of a costing task team to help the WHO Global NTD Program identify and put figures on key interventions and economies which will enable us to achieve the 2030 roadmap goals. Over the coming months, the costing task team will be seeking to fill in the gaps in order to ensure that in all the advocacy work we do, we can give confident and precise answers not only about the cost and budget needed for specific programs and interventions, but on the saving we can make. Can you hear me?
Yes, we lost you for a moment, but you come back.
Yeah, that's what I realized. Okay, I was saying over the coming months, the costing task will be seeking to fill in the gaps in order to ensure that in all the advocacy work we do, we can give confident and precise answers, not only about the cost and budget needed to specific programs and intervention, but on the saving we can make to global and national budgets through our cross-cutting initiatives and through working collectively towards a common goal. I hope that this work will freeze all of our effort throughout the community to ensure that NTDs are properly funded on separate national and national levels. And also that we ensure as a community that we are making the best possible use of our resources through collaboration and identification of common goals and causes with colleagues throughout the global health sector. In that spirit of collaboration, then I'm delighted that we have here today an excellent example of working together. The uniting effort for innovation, access, and delivery platform, co-convened by UNDP-led Access and Delivery Partnership, the government of Japan, the UHIT Fund, has been exploring the best way to support countries in accelerating and improving the innovation, access, and delivery of NTD medical product and technology. WHO and United Effort formed a partnership in 2021 to work together on supporting the development of a country toolkit for national NTD investment. I'm very glad to see the first output of this constructive collaborative partnership. Today's meeting is an opportunity for us to explore together the criteria we have for evaluating a country's need in NTD terms, and I'm very much looking forward to hearing the fruits of your discussion. Thank you all again for your invaluable interest and support in this important work. I wish you a most productive discussion. Thank you. Back to you, Chair.
Thank you. Mandeep, the floor is yours.
Thank you very much, and thank you, Dr. Sesefal, for your opening remarks. Good morning from New York. I'm Mandeep Dhaliwal, and I'm the director of UNDP's Health and Development Group globally. And on behalf of the partners of the Uniting Efforts for Innovation, Access, and Delivery platform, I'm pleased to welcome you all to today's consultation. Uniting Efforts is a collaboration launched in 2019 by the government of Japan, the UNDP-led Access and Delivery Partnership, and the GHIT Fund. This platform brings together a funder of NTD, TB, and malaria health technology development, the GHIT Fund, with its diverse portfolio of health technologies, and the UNDP-led Access and Delivery Partnership, whose partners work with governments and country stakeholders to strengthen health system capacities to enable greater access and delivery of health technologies to patients in need, and the global health leadership of the government of Japan, which is a critical partner of our Uniting Efforts partnership. Our aim is to promote dialogue among key stakeholders on the means to accelerate and improve innovation, access, and delivery of health technologies for unmet health needs in low and middle income countries. Thank you, Dr. Sesefal, for your opening remarks, for your active and excellent collaboration with WHO, and the initiative of your team to strengthen national TB responses. We heard from you already that NTDs affect the world's poorest people, but they have often failed to attract the focus and the funding needed, including to develop new technologies and tools. And even when these tools are developed, they remain out of reach for most of the people who need them and where the need is the greatest. The challenges are diverse, but a lack of funding and prioritization is a key one. UNDP has experience working with WHO and partners in supporting innovative financing strategies for health, including through the development of national investment cases for NCDs, tobacco control, mental health, and other health priorities. Our experience in working on these other diseases and health priorities have shown that national investment cases are a useful advocacy tool to prompt evidence-based resource mobilization, policy changes, and spur program implementation for greater impact. WHO and Uniting Efforts began to conceptualize this idea of a toolkit to help countries make investment cases for NTDs before the COVID pandemic. Today, I believe this work is even more important than ever. We are all aware of the increasing pressures on health and development financing in low and middle income countries. I believe this work is even more important now. In 2020, we published a report on the funding landscape and financing opportunities for health technologies to treat neglected diseases. The report already warned that COVID-19 would have a negative impact on the most neglected diseases. And we've got a report out from the World Bank today about slow growth over the next couple of years. This is going to have even more of an effect on financing for neglected diseases. This report that was published emphasized the need to work even harder to address the setback caused by the pandemic and to continue making progress towards the NTD 2030 targets. We know that failure to do so will exacerbate and deepen existing inequalities. As we have hopefully learned, strategies to improve the responses to neglected diseases, including investments in resilient health systems, are and will be essential to strengthen the response to COVID-19 and future pandemics, as well as other health and development priorities. I'd like to recall the key recommendations from the Uniting Efforts Guidance Note for Neglected Disease Investment Cases, which was published in 2020 as a precursor to this work. I believe some of these are still relevant, and I hope that our discussion today, we will have an opportunity to assess how we are following these. First of all, investment cases must be country and demand driven. Local context is important, even if local data is not always available. Buy-in from the highest political levels is critical, but at the same time, we must not sacrifice action in the efforts to secure secure this kind of political buy-in. The involvement of key actors outside health ministries, outside the health sector, is crucial. Simplicity leads to better communication and usability, and integrity of data and objectivity of results must be protected. So I'd like to thank the Ministry of Health of Ghana, the WHO Global NTD Program, and RTI for their partnership in this work. And finally, my thanks to all the participants for your interest and support. We have quite a number of people online today registered for the webinar. We look forward to your input in the current prototype and your guidance, support, and ongoing engagement to advance the design of the next steps, all with the ultimate aim of improving health outcomes in terms of NTDs and ending the neglect of NTDs. So thank you very much, and I wish everyone a very, very productive discussion today. Thanks, Judith. Over to you.
Thank you very much. Thank you both, Dr. Sosei and Dr. Mandeep, for your great opening speech. That gives us a big encouragement for our discussion. Good morning, good afternoon, and good evening, everyone. My name is Xiaoxian Huang. I'm health economist at WHO Global NTD Program. And I'm also the focal point on the WHO side for this project. I will be sharing my screen. Okay. Let me know if it's in a good mode. And are you seeing my screen correctly? I can't hear any feedback.
No, it's few, but yes.
Okay. Okay. Thanks. So I always will spend a few minutes to give you an overview of this project and also explain the key items in this webinar. In 2021, when WHO discussed the work with countries with uniting efforts, we found a common ground of interest in terms of how to support countries to more effectively mobilize resources for NTD interventions and NTD programs. And we decided to build a joint project aiming at producing a toolkit that will be practical and user-friendly, that supports countries and partners to develop national investment case for NTDs. At that moment, the investment case was used successfully in many other diseases programs, and we think this could be a very helpful tool for countries. We would like to have this tool scalable, operational, and sustainable. And for those purposes, we need this to really driven by country needs and interests. And we also expect the tool can help countries to better participate to national budgeting, planning process, advocacy, and decision-making so that they can really mobilize resources for national response to NTDs. What will be the target users for these toolkits? It's mainly stakeholders in a country. It could be national NTD program planner managers. It could also be in-country actors that are in need of mobilized resources for NTD programs and interventions. But it can also be the research team and partners that are aiming at creating economic evidence for investment, for better investment in NTDs. When we plan this project, we also set some characteristics that we expect to obtain from this toolkit. It should allow for inclusion of all NTDs that is endemic in a country. It provides information on program cost and the value for money. It should allow for prioritization of resources use. To be able to participate to national budget negotiation and planning, this toolkit should link to the general health system and allow countries to use existing data. it should be user-friendly so that countries are not feared to use it. And also it should provide some linkage with other existing tools and platforms, such as tools for integrated planning and costing for NTDs, TPAC, and the integrated health tool, which is a multi-disease platform for national costing and planning. Okay, so one particularity of this project was that we intentionally set a step to build a prototype before we go to the final product. Why? Because we observed in many other projects that when we come to a consultation with a close to final products, we don't have enough time, resource to address the feedback we receive, and it's too late to change substantially the product. So this time we want to take that time to come up at first with a prototype which has smaller scale, but give you a concrete example how the toolkits will look like in the last. And through this consultation, we will understand whether this tool design makes sense, answer country's question, and whether it's the good, we are in the good direction. And based on your feedback, we will readjust our project, our project. So that's what we want to do from this webinar. In this webinar, we will present the toolkits and receive feedback from you on the current design. We also want to discuss what we should do for the next steps, whether it's to expand to other diseases, interventions, or pilot it in countries. What will be the good direction for this toolkits. And also we want to facilitate a multi-sectoral engagement and dialogue with actors not only within the NTD community, but also beyond. Okay, the next step the item will be to have Dr. Rachel Nugent to present the toolkits, and then we will have a panel discussion where we will have the different key actors that potentially can be interested in using these toolkits to share their perspective and their feedback on the toolkits. And also we will have a 30 minutes Q&A session with the audience. So that's where you can ask your question and we will try to answer. After that, we will wrap up with some takeaway message that we got from those discussions. And also some preliminary thought on the next steps. Some housekeeping tips. You can get the interpretation in French and English by clicking on this button, interpretation, and choose the language. This meeting is recorded, and also you can ask your question either through chat or through a Q&A, and our team is closely checking the chat. We can either answer you by writing in the chat or bring it to the oral discussion in the Q&A session. Of course, you can also raise your hand during the discussion session so that you can participate to the discussion in an oral way. And also you might also notice that the toolkits prototype has already been shared with those registered participants before this webinar, but if you haven't received it, you can let us know and we will send it later. And so we will give you other opportunities to share your feedback through a survey, a post-consultation survey. So check those opportunities, do share your feedback. Without further review, I will turn the floor to Rachel. Thanks. Rachel?
Thank you, Xiaoshan. And yes, thank you very much for the nice introductory talks. I really appreciated how well we have been set up for this discussion from Dr. Sosei-Fall and of course from Dr. Mandeep and Xiaoshan. So my task here is in relatively quick order to introduce everyone to this toolkit that we're discussing here. So I'm going to share screen with you and go through some slides to help you understand what we've been discussing here as I try to get the slideshow presentation view. There we go. So unless I see something in the chat, I will assume that you can see the presentation view of the slides, and I will go ahead. First, in addition to thanking the sponsors and our partners at UNDP and at WHO and at GHIT Fund, we've been working very closely together for some time now on this toolkit. I want also to thank my colleagues at RTI International, especially Adeyemi Okunobi, Leah Jameson, and Chebis Ona, who have formed the team that developed this prototype toolkit, as well as our colleagues at RTI who have been working on NTDs for many, many years through the Act to End NTDs East project and prior versions of that program. So you might ask, why RTI? Myself, I'm Rachel Nugent. I'm vice president, just retired actually, former vice president in non-communicable diseases at RTI International. And our team has been working on many of the investment cases that Mandeep referred to, that UNDP has worked with countries on and helped countries develop the evidence and the arguments to build support for the important health issues that they have. So we have a lot of experience with investment cases on my team. We also, as many of you know, and I just mentioned, we have a lot of experience at RTI on neglected tropical diseases as a partner with USAID and with WHO and with many, many countries and many others on working on NTD program implementation. So in a sense, there was a very good marriage there, and I appreciate all of the inputs that our RTI NTD colleagues have given us and guided us in the development of this. So without further ado, I want to acknowledge all of that input and much other input from different experts and colleagues that we've spoken with around the world as we do this. And then last but most definitely not least, Brian Asari and his NTD division colleagues in Ghana, who agreed to allow us to use the case of Ghana as our first example to use the data and the experience and conditions in Ghana to develop this prototype. So I will go forward here first, and I realize there's a lot of different experience among the people on the call, among the audience, and so thank you very much for joining wherever you're coming from and whatever your interest is here. Some of you are NTD experts, some of you are investment case experts, some of you are budget and programming experts, and many other things. So I'm going to start with just the point of what is an investment case. And this has been introduced to some extent already by Shaoshan and Dr. Mandeep, who have said, why is this an important step to take for WHO, UNDP, and the countries that they work with? But very specifically, let me share with you what we are generally planning to do when we do an investment case. An investment case describes disease burden for a set of diseases, or sometimes just one disease. It surveys the policy environment for feasibility of actions that can be taken. It uses evidence, and I'll speak directly to that very shortly, particularly for interventions and what are the most effective interventions. We look at the coverage levels relative to UHC, what is existing coverage, what is planned, what seems feasible in a certain time frame, and we define some pathways to scaling up coverage based on the country's assessment of where their priorities are, what they can do, what they need to do, what their goals are. We look at bottlenecks to try to understand access, affordability, and acceptability issues around technology and other aspects. And of course, our aim is to measure the costs and the benefits of interventions, of scaling up specific evidence-based interventions, and to arrive at some outcomes that are economically based to help us understand what the economic implications of scaling up interventions would be. We measure that in terms of net benefits or benefit cost or return on investment or some combination of those. And then sometimes an investment case will look at the financing aspects, which is really at the heart of this. How do we identify financing and how it can best be spent? So we may look at current health spending against the needs or relative to the needs and identify opportunities for funding, opportunities to address the funding gap. We have not done those last 2 points in this particular investment case. It can be done. It's not done here with what I'm presenting to you. So you do have access to the toolkit. I'm sorry, I'm trying to move our pictures out of the way. Whoops. You do have access to the toolkit through the links already sent to you, and there are several pieces of it that you can look at. The Excel-based tool, and I want to underscore, we've used Excel, which is very commonly available across the world. Many people have access to it. Many people are used to using it. It is the platform that is very often used by WHO and its partners in providing and developing toolkits for country use because of its familiarity. So we used that for that reason. There's a user guide that step-by-step guides people through how they would use the toolkit. There's a detailed technical annex that describes the methods. And then there's a summary using PowerPoint slides. All of that is available to you. And I will not in any way be able to do justice to all of those pieces in this short time, but I want you to know that you can refer to those and of course come back with questions and suggestions, which is what we hope you will do. So there's a lot of work being done in the area of neglected tropical diseases, a lot of work yet to be done. And the roadmap, of course, from WHO is what guides that work in many countries, along with their own NTD strategies or country global health, country health strategies. Here, we knew we couldn't cover the full landscape right away. So we chose a country, we solicited a volunteer, and Ghana stepped up to the plate to volunteer to be the pilot country. We identified 3 of the many NTDs, 20 plus NTDs that are priorities in the roadmap. And we said we could handle about 5 interventions, 5 priority evidence-based interventions in this initial modeling. So you'll know, I'm showing you this because you know that we picked several NTDs out of this very, very broad landscape here, which many of you are quite familiar with. And you can see not only are there many NTDs, and they are very different from each other, most of them, but there are also different goals, and those are listed there at the top. And this comes from the WHO NTD Road Map. Some of these NTDs are scheduled for controlling the number of cases and managing those cases. Some are scheduled for elimination as a public health problem, some for elimination through interruption of transmission, and some for eradication. So that each of those different goals, it has a lot of evidence and consideration behind them, and they provide guidance for what will be done in countries and what can and should be done in countries to address each of these different NTDs. So what we did was we wanted to, and you'll see again at the top of the slide, the criteria that we used to select the 3 NTDs to start with to develop the prototype tool, because we can't start with everything, as I said. We wanted to select a few NTDs that were endemic in multiple countries with relatively high prevalence, representation of those target categories that I just mentioned. We tried for that. We didn't represent all of those different target categories, but we did represent some of them. And of course, country and partner recommendations about which NTDs might be the most important to start with. So you can see we chose onchocerciasis, lymphatic filariasis, and leprosy because they do cover some landscape of the broad landscape that I've mentioned. They do cover a number of those criteria. some of you on the call are experts in one or more of these different NTDs. I am not, but I've learned a lot about them in this process. Lymphatic filariasis, of course, transmitted by mosquito with some sequelae that you can see here, very important. Lymphedema, hydrocele sequelae. Onco, again, a vector transmitted, the vector is black fly, with some important sequelae, including visual impairment, even blindness, skin disease, and epilepsy in some cases, and then leprosy, a bacterial disease with different levels of disability. So we looked at the diseases themselves, the cases, and then these important sequelae, and measured the ability to intervene on those. So briefly, our methodology, a very deep literature review on 2 questions. First, what do we know about the health and economic burden of each of these 3 NTDs? And second, can we identify 5 or more, roughly, distinct and cost-effective interventions for addressing each of these 3 NTDs? 5 is not a magic number, it's just what we thought we could handle in the time frame and resources that we had, and that's still quite a bit. How about the data sources? Here, I think all of you who work in NTDs know this can be a big issue. In fact, that was the first big issue raised to us about whether this could be done is, what about the lack of data in many countries, maybe all countries, about some of these diseases, and that's certainly an issue, and we can talk about that. We looked deeply into the peer-reviewed literature, global databases, and spoke with many different experts, especially, of course, in Ghana, once Ghana was chosen as the example country, and NTD experts from many places. And then we did some modeling, fairly simple epidemiologic model to look at where we are now, where let's talk about Ghana here briefly, the past 20 years, and then what we would project for the future in the status quo, and then given the interventions that we introduced, what would that look like? And what would the epidemiology look like with the interventions in place? And then we developed an economic model that looked at the costs, the health impact, which we translated into value. We monetized the health impact, reduction in mortality and morbidity. And then we produced these economic measures that I mentioned earlier, benefit cost ratios and return on investment. So very, very briefly, I'm going to give you a little insight into both the epidemiologic and the economic modeling. The epidemiologic modeling, as I said, a relatively simple approach. We did it for each of the 3 NTDs by age group and by sex. We looked at the history, so the time trend, and you can see this example here in the right-hand side of the chart. We looked at the past 20 years of disease prevalence with all of the things that can affect that, whether it be weather, things happening with the vector transmission, things happening with interventions and efforts to control and so on. And then did a log normal nonlinear generalized regression to project into the future based on that past. So we use the prevalence rate as the main independent variable, and you can see how that works over time. And we relied on the global burden of disease for prevalence. And we had a lot of discussion about that. It's preferable, of course, to use data produced by the country as much as possible. But in most cases, we really didn't have enough data. We used a lot of data from Ghana, but we didn't have enough data on the burden of disease. So we relied on global burden of disease, GBD, which of course is available for all countries, which is a big benefit for any country that doesn't have enough of its own data but wants to do this model. Moving on to the economic model here briefly, going from the top on those boxes first, we wanted to measure the economic burden of these 3 NTDs. And economists, as some of you will have experienced, talk about different kinds of costs. So we looked at the direct costs, which are what do people pay for care when they have an NTD, care, treatment, and hopefully cures excuse me, not always is that available, but there may be ongoing treatment that is needed. So direct medical costs are sometimes very often a big burden for families. Those are not always paid for through health programs provided by the government. So it can be a very big burden for families or for the government if they're paying for care. And then there are non-medical costs, which almost always fall on the patient and their families, getting to the clinic, staying in wherever the clinic or the hospital may be that they have to go, having caregivers. So those are the direct costs, whoever the payer is. And then on the other side, you see indirect costs. And this is often the largest proportion of the health burden, is the loss of productivity, sometimes loss of jobs, loss of income that families and people affected experience, and the economic loss from early mortality or ongoing disability. So the loss that happens when people fall out of the workforce early or even die, and their families and others lose the benefit of their of having them still alive in the family. So that's a very and there's a we have, I don't know if you can see it because on my screen I can't, but below productivity loss, we divide that into two ways of measuring absenteeism and presenteeism, which is if people are still at work, but they're not able to work as productively as they used to before they were afflicted with one of these diseases. That's called presenteeism. And then absenteeism, of course, is having to be out of the workforce temporarily or for a long period of time. I don't know if you can see those boxes, but they're there at the bottom. Finally, on this slide, you see 3 time horizons that we used for this particular work in Ghana. A 5-year time horizon to project the costs and the benefits forward for 5 years, because this fit Ghana's plan, its NTD strategy, and they wanted to see what could be done within that time frame. A 10-year time horizon that aligns with the SDGs, which will be completed in 2030, and then a 30-year time horizon to sort of capture a life cycle. Generally, these cases of these diseases occur among adults, and so we wanted to try to capture what could be the benefits as well as the costs of intervening and getting reducing the burden across adult lifetimes. So moving on, a little bit more detail on the economic, just to point out, we looked at basically 2 versions. We used that same framework, and we looked at the status quo. That's panel A there on the left-hand side. You can see that's if we maintain the status quo, we project into the future. What does that look like in terms of mortality and morbidity, direct and indirect costs? And then on the right-hand side, we introduced the box there that is the interventions, and we assessed the effectiveness of those interventions. How much could they reduce the number of cases, the severity of cases, the loss of life, etc., and measured the costs and the benefits of having those interventions scaled up. And then those you can see down there on the bottom. And again, on the very bottom, I can't see the whole thing on my screen, but I hope you can. We produced a measure of return on investment and benefits and costs for each of those interventions, and the interventions as a package. So with all of that background there on the methodology, let's move to Ghana, the case of Ghana, and show you what we did and what we found. So again, the 3 NTDs that I mentioned that were chosen, the types of interventions, similar types here: preventive chemotherapy for LF and onco, and then case management for all 3 of them. How do you reduce the disability or reduce the health burden that having a case of one of these diseases might cause? And different kinds of case management, including deploying surgery camps and using self-care education and kits to support people for self-care. And then for onco anti-epileptic medication was part of the case management. And then finally for leprosy, increasing case detection. So trying to detect and do contact tracing at a higher rate than what Ghana has been doing. So I jumped around a little bit there, but you can see sort of the range of interventions that we used, and this a little bit on the specifics. All of that selection of those was based on the very, very deep dive into the literature about which interventions are most effective and where we could get cost information about what it would cost to implement those interventions. So those were selected through a fairly laborious process based on the evidence, but of course there are other interventions that might be more appropriate in different settings. These are not the only interventions that could have been chosen, but for Ghana, these were chosen. To take a quick look here at what the toolkit looks like, if you haven't looked at it yet, you can see on the left-hand side there a quick overview. Ghana as the pilot country. This is Excel-based, the user guide, 4 main worksheets that people can see and that they can work through. And those 4 are under the table of contents, sort of in the lower middle part of the slide here. A worksheet for interventions, a worksheet for inputs, a worksheet to show the results, and a worksheet that shows the economic return. So those are the 4 that someone would mostly see. And then there are many hidden worksheets and data sets that are available to look at. They can be unhidden, but they are all behind those 4 that are the main ones that you look at. And so I'll show you a little bit of that. The input worksheet here, the top part, there are some basic data that go into every investment case. You can see socioeconomic inputs such as GDP, value of a statistical life year, wages, inflation, so on. Each of those are to be input by the country. Those will all be different in each country. And you can see the little arrow there saying country-specific inputs. Those numbers are put in by yourself, whoever's working on this in country, for your country. And they can be, adjusted. The cells below, we have the example here of lymphatic filariasis, where we have some of the epidemiology, and then a lot of the other types of things I mentioned before about what happens when people have a case of LF in terms of presenteeism and absenteeism, working days lost, et cetera, how we measure those economic measures that you've seen, and we put values in for those based on the literature. You can see the sources on the left-hand column and the values on the right-hand column. Those can also be changed if you have, whether you're in a country or whether you're in an agency, if you have other data that is more appropriate for where you're working or for your country, you can change those values. But these are all evidence-based, the best that we could find, and they give a place to start and maybe to finish if there is nothing better. So this is an example of one of the worksheets that you would be working with. This is just a representation of the results, so the economic results, because I think I'm about out of time, or maybe a little bit over. So this is just a summary slide that shows the results for Ghana for the 3 diseases, LF on the left, onco in the middle, and leprosy on the right. You can see the bars that show the total cost and total benefits for the package of interventions, not the individual. You can see the individual ones in the toolkit, but we aggregated the results of costs and benefits for the package for each of the diseases, and then the ROI is in that row in the middle, return on investment. So for LF, $3.20 in economic benefits for every dollar spent on implementing the interventions. That's what that means. For onco, a much lower ROI, barely breaking even, barely positive there. And then for leprosy, quite a high ROI, $27.40 for every dollar of benefit for every dollar spent on the interventions. Again, the interventions are repeated there at the bottom that I already spoke about. So that's just a quick summary of what we obtained for Ghana. Every country will look different in terms of the numbers, but then let me finally wrap up. Lots to say here, but we've been discussing and hope that there will be some discussion here about how this can be applied, how it needs to be further developed. Obviously, it doesn't have everything in it that all of you who are working in NTDs need to think about and deal with. There was a very, very good collaboration with a lot of input, but there needs to be more input, because as a prototype, this really is, you know, our, with a lot of expert input, our effort to represent what you're dealing with, but you who are on the ground have much more to add. It needs to be adapted to countries and needs to be tested and then improved. And it may need several iterations to become final, as any model does. So we would hope that there might be opportunities for pilot testing it in some other countries that might be interested. And of course, expanding to include additional NTDs and additional interventions so that it can be as comprehensive as what countries are dealing with in trying to address this problem of neglected tropical diseases. With that, thank you so much for your attention, and I will stop and look forward to our Q&A. Over.
Thank you very much, Rachel. That's a great presentation of this tool. We begin to receive questions. Please continue to ask your questions through a Q&A and chat, and we will discuss those questions in the Q&A session. Now, I'd like to turn the floor to Isaac to moderate this panel discussion. Over to you, Isaac.
Thank you very much, Xiaoshang, and thank you very much, Rachel, for the presentation that provides the background for the next panel discussion. Welcome to everyone. Good morning, good afternoon, good evening, wherever you are. I'm Isaac Chikwana, the Senior Director of Access and Delivery at the Global Health Innovative Technology Fund. So in this session, we have three distinguished panelists who are going to share their experiences and views on the toolkit and their experiences on investment cases. And without further ado, we'll start with Dr. Brian Adu-Asare from the Ministry of Health in Ghana. Brian is a pharmacist and a senior technical advisor in the Ministry of Health. He's currently leading the health technology assessment at the Ghana Ministry of Health. Brian, as we have already seen from Rachel's presentation, Ghana played a key role in the development of this prototype. Could you explain the input provided in the development of this phase of the toolkit and your overall impression of the toolkit as of now? Brian, over to you.
Thank you so much. And first of all, I want to thank you for having me. And I want to acknowledge the team from Ghana, Dr. Benedict Kwao, Dr. Joseph Opare, who have also played key roles in getting this through. So in terms of what our impressions are on the tool, I think that we both know that when it comes to investments, a lot is considered in the context of especially lower middle income countries. So first of all, putting this together, there were a few constraints, of course, when it came to the data inputs, when it came to what specific country level data to put in. But the tool actually gives you the opportunity to play around the input parameters as well. So even when there is uncertainty in some of the input parameters, you could actually test by way of a sensitivity analysis and see what the potential range of values could actually produce and yield. So that is a very good thing. That addresses data constraints in the country context. So it's good that the tool is designed that way. The other bit also is that looking at the tool in general, we think that apart from its ability to address these constraints around data and uncertainty, it also gives us the ability to address the competition for resources, amongst various public health interventions that needed to be funded. So that is also another useful aspect. The country input there has been the fact that despite the constraints in allocation, resource allocation for the NTDs, even in our context, we are confident that applying this tool would give us the needed data and the outputs that would require to do policy level advocacy that will lead us into some form of allocative efficiency in how we allocate resources to various interventions, including NTDs, and to help us to advocate for even more allocation in that space, because this is the sort of data that you need to be able to engage, and I'm happy that the costs, it's not a cost-effective analysis that is done. It's more of a cost benefit, and both ends in terms of costs and benefits are in monetary terms. And this is the sort of language that we need to engage with non-health sectors that are making decisions when it comes to resource allocation. So that is very, very good. In terms of the broad use of this tool, we are confident that it will help in decision making, of course. It would also help in the area of resource allocation, like I've said. But more importantly, also, it helps us to be able to engage stakeholders. So when you have this type of information, you are able to communicate based on evidence and then highlight the potential value of investments in these areas. And from the presentation that Rachel has just done, you could tell clearly in the output, the return on investment is very clear when you look at it. One thing that I would also highlight is the idea of the packages. You see, so because we are not dealing with individual interventions and the tool has been able to give you a package approach, it means that you can actually superimpose a country strategy within this tool as an option. So because we know from evidence that sometimes when interventions work alone, the outputs are different when compared to when you put interventions together. Okay, so you will not be able to assess interventions as individual interventions and be able to come up with meaningful things. But when you have it as a package, it means you can superimpose a country NTD strategy within this as a package of interventions and actually look at how it plays out. And you can use that to do stakeholder engagement and get people to understand that this course of action compared to the other course of action can produce this outcome. And that is very, very useful. Maybe I would end by adding that performance also is very important. This tool will help countries to be able to assess performance. As you implement a program, you could actually be collecting live information as you implement and putting it in to see whether you are in the course of delivering the value that the analysis promised or the analysis projected. And that is also very, very important. I'm also happy that there is documentation for countries to be able to use when they want to be able to adapt this tool to their context. In a nutshell, I would say that it's a very, very useful tool. Its applications is actually subject to the creativity of the context within which they are to be applied. But then to pin a few of these usefulness down, I'll talk about its value in decision-making, its value in resource allocation, the ability to give you a tool for stakeholder engagements in the space of policy advocacy, as well as performance assessments as you implement interventions over. I'll pause here, and then if there are further questions, we can respond to it. Thank you.
All right. Thank you very much, Brian. You mentioned the value of investment cases in advocacy and in advocating for resources, but you also mentioned that there were some challenges with data uncertainties. But this is not the first time Ghana has used investment cases in the NTD program. So I'm sure you have key lessons learned from other investment cases that you have done before that could be applicable to this tool to deal with these data issues. Do you have any examples of how you deal with these data uncertainties? Because I think we all understand that if the data is not correct, then you have problems in justifying the rationale, and you can't use the tool for advocacy. How do you deal with that?
Thank you so much. That's a very good question. I think that the absence of data in putting into some of these models, a lot of the time, if, for instance, the quality of the data is low, and then or the data is not available, sometimes you're able to benchmark against what is available within other contexts that you can adapt. That's one. The second approach is also that you can also do some what we call a sensitivity analysis, in terms of the fact that you can make a guess or an informed guess of a value and be able to simulate under scenarios and be able to play out the potential impact of that particular piece of information and its value in terms of the added value, in terms of accuracy, in terms of predictive value, what that additional information can get. We will not be able to get all the data that we need to be able to answer all questions that we need to answer, but then it comes to the point of value of information analysis, that sometimes the cost that you incur and the resource inputs that you incur to even generate data to be able to answer some of these questions, the question as to whether it's even worth that investment is another issue altogether. So for us, it's about being able to benchmark against similar contexts. It's about being able to do scenario playing, and informed scenario playing with the data that you have, and be able to assess the impact of the value of that piece of information on the outcomes. A lot of times, sometimes the accuracy or the potential impact of that piece of information could be very high, and sometimes too could be very low in terms of it's changing your decision in playing out what the outcomes could look like. So this has been some of our lessons in Ghana when it comes to the availability or lack of data, or sometimes even poor quality data that is available. You just need to play it out and see the potential impact and assess whether it's worth making an investment to get more quality data to put in.
Thank you very much, Brian, for that. I really like your point about the value of data. At some point, you have to make a decision on whether the investment is worth it. Thank you very much for that. I'll come back to you at the end of the session. For now, we'll move on to our next panelist, who's Professor Khalifa El Musharraf. Khalifa is an associate professor and director of public health programs at the University of Birmingham in Dubai. He has a lot of experience, more than 20 years of experience in academia, ministries of health, international organizations in Africa, Middle East, and Europe. This is just a summary of all his accreditations. So I'll stop here. Khalifa, I hope you forgive me for highly summarizing your bio. You have a lot of experience with both the development and use of investment cases at national and international level. What are your key lessons on what makes an investment case effective and useful? I understand you have a PowerPoint presentation to guide us through your intervention.
Thank you very much, Isaac, and I hope you can see my presentation in the screen. Can you see?
Yes, I can see the lead, or at least for me, I can see the lead slide.
Yeah, perfect. So thank you very, very much for inviting me. I'm really glad to see this investment case being developed for this particular important area. I've been working supporting WHO and UNDP for the last few years in conducting investment cases, more than 12 countries, and in different areas, NCDs, primary health care, nutrition, air pollution, assistive technology, road traffic accident, physical activity. So there are kind of a proliferation in the last few years in investment cases. So in my very short presentation, I will be highlighting 4 or 5 areas just to give some kind of feedback regarding key lessons learned through my previous work in different NCDs, suggestions for next steps for investment cases, and then specific suggestions for this toolkit. And then I will also highlight major concerns that usually policymakers face for budget allocation and priority settings, and then share two quick success stories. So from the work in investment cases across different contexts and different disease area, I can highlight 6 areas that makes the investment case effective and useful. One is a clear estimation of the disease and economic burden before starting the investment case. This will set the scene, build the engagement, and build the rationale why we need to invest in this area. Then aligning with national priorities and time scale. And I'm glad that Rachel mentioned the different time scale that they use, and one of them to align with the country needs. The third point is the consideration of different scenarios. Usually at the country level, they like to see different scenarios because this will help them for their prioritization and decision-making. Building political buy-in and stakeholder support at early stage is really crucial. And I will highlight that in the success stories. The investment case should be seen as a living document rather than just an end product that is regularly updated and monitored. And it's also important to integrate sustainability plan for the intervention beyond the initial funding period as part of the recommendation. But in the context of the proliferation of methodologies and a diversity of investment cases being used by different countries across different diseases and across different priorities, I think there is a need now to maybe pause a little bit and think about a few issues. One, there is really a need to develop a standardized framework that guide the development of investment cases. Two, integrate technologies. The WHO, UNDP, and many UN agencies use the One Health tool, which now is converting into the integrated health tool, which help countries for costing exercises, for return on investment analysis, and all these investment cases. I think it's the time now to integrate more kind of machine learning, artificial intelligence, data analytics into this and bring it to more kind of web-based, mobile-based applications to help streamline the work. The third point is there are many health economists working in different investment cases with UNDP and WHO and other agencies, and it's time to promote collaboration between those economists who are working in this area to make sure that they're using the best practice. The fourth point is we need to build local capacity, at Ministry of Health, at local organization to be able to conduct and lead on those investment cases and to use a clear feedback mechanism from countries to improve and these investment cases. These are a few suggestions that I look at the NTD's toolkit. It's really a great work in an area that complex and difficult to come up with these kind of methodology to address these complex issues. Moving forward, we need to focus on these 5 things. It's important to ensure replicability in other countries. People can use it in other countries easily and replicate it in their settings. We need to ensure also scalability to other NTDs and other interventions. We need to make sure that the tool is user-friendly, can be used at different settings. Many people talk about the data and the requirement, so it's important to address those concerns about that data requirement. And it's important thing is to provide guidance also on how to use the results for advocacy purpose and to be part of the guideline. When decision makers decide for health priorities in the light of the investment cases, usually there's major concerns for budget allocation and resource mobilization. One, political priorities, government agenda, and urgency of the disease. And we all notice that how in Ebola, for example, epidemic and COVID, how the priority shifted and the allocation of resources shifted to other diseases. And this will continue. So people need to be aware of that. The role of the external funding and influence what diseases will be supported. That will also influence the budget allocation. The burden of the disease and the health outcomes will determine. The good thing that the return on the investment now provide a new way of helping policymakers to make a rational decision on where to invest and allocate their budget. And then the most important part is the health system capacity. Countries will focus on intervention that they can deliver with their limited resources and limited capacity. So these are from my point of view, the concern that we might need to address when we think about budget allocation and prioritization. So I will finish with these two stories. So this is the first story with working with the colleagues here in UNDP and WHO in 6 investment cases in the 6 countries in the GCC. And I think that the key success factor was the early engagement with different political entity in those countries and government organization to achieve this comprehensive investment cases. And that early engagement helped to progress into the investment case and build that kind of momentum. And the second story is from Georgia, where I work with local technical team from different Ministry of Health at the country level to work on this investment cases and engaging local technical expertise. It's really crucial for buy-in and to make sure that we are doing a relevant investment case. Isaac, I will stop here. I'm happy to answer any questions at the end. Thank you very much.
Thank you very much for that. It's really interesting that the suggestions that you give are actually quite linked to some of the questions we're getting from the audience, about what needs to happen next in terms of the tool. But just to pick on one of those, you mentioned user friendliness. There was also mentioned, Shashank mentioned it at the beginning, and Mandeep also mentioned simplicity. If you're to pick one or two things about the tool that you feel are a must do in order to move forward, what would that be?
So just imagine I work in a Ministry of Health in one of the African countries. I'm from Sudan. And just imagine that I'm in the Ministry of Health. And then I have a tool for NTDs. I have another tool for NCDs. I have another tool for air pollution. And I have another tool for assistive technology, different methodologies. It would really be difficult for us in the Ministry of Health to manage all these different methodologies. So it's important to integrate all this in a simple framework that if I have data, I can enter the data. If I don't have the data, the system can generate a similar data from similar context automatically to help me make a quick decision. How can all the health information system can feed into some kind of a platform that will help the policymakers in a click to make a decision. And now with the machine learning, artificial intelligence, and data analytics, it's time now to bring different brains from different background to work together on this.
Thank you very much. Integration. So before I move on to the next panelist, Sam, I just wanted, we have Rachel on the call as well, who's been part of developing this tool. Rachel, from what Prof. Khalifa has said, what do you think is viable or feasible in terms of integration of all these tools? You have also been involved in developing different tools with different methodologies. What do you think is possible?
Yeah, that's a very great question. And we have been talking for some time about a UHC investment case. I think that is sort of it would be an ultimate goal because countries are moving towards UHC, they are aspiring to UHC. And the whole point of doing these investment cases, well, a couple of points, but one is really to help countries set priorities that they can achieve and to do it in a reasonable time period and to have some predictability, as well as, of course, then to demonstrate, what is going to be most attractive for funding. What do those priorities tell us about what should be funded and when? So looking at the breadth of what countries are dealing with is the desirable thing. And Dr. Brian Asare, I think in Ghana, they've done a lot of that. Other countries have done as well. Kenya, many countries are thinking and working on UHC. So we ought to be able to come up with a model that supports that work, that helps them in that work. And I think WHO and its work on the One Health tool to advance that, to make it more available on the web, which will come about in the near future, that will move us in that direction. But there's a lot of challenging methodological issues to deal with about how the interaction happens. If you reduce the burden of one disease, how does that affect people's exposure or vulnerability to others? So I would say that the scientific evidence is not quite at the level of what the policy needs demand, and that requires us to all just work better and harder.
Thank you very much, Rachel. I'm sure we have, if we had more time, we could go on and on discussing about how we could move forward on this. So we'll leave it at that for now. And then we go to our third and final panelist, who's not a stranger to the use of investment cases in mobilizing resources. We have Sam Meyer, who's the Vice President of Public Affairs at the End Fund. And his role is really mobilizing financial resources and attention to NTDs. And I'm sure you use investment cases in your work, Sam. So from a donor perspective, what do you see as the role of investment cases in mobilizing resources and investments for NTDs?
Well, thank you, Isaac, for the kind introduction, and thank you to all the fellow panelists, and especially those at Uniting Efforts. I know this has been, this is yet another milestone in a very long and I would say committed journey that you are taking on this topic. So thank you for your leadership on that. And of course to Dr. Sose Fal and the leadership from the WHO team, as well as RTI and everyone behind this important and exciting work. So from a donor perspective, firstly, let me give you a sense of where I and my organization are coming from. For those not familiar, the End Fund is a private philanthropic initiative that works closely with philanthropists to pool funding and reallocate those resources to support the local leadership of national NTD programs. So for us, making the right investment case, or the case for investment, because I think the term investment case may mean different things to different people, and I appreciate Rachel's comprehensive definition earlier. But for us, making effective cases for investment is a fundamental part of our day-to-day work. And traditionally, of course, and even still today, most of these cases for investment have focused on the health and the social returns on investment in NTDs. So, and I think with the scale of the burden caused by NTDs, there's no shortage of these kinds of cases for us to be making to donors. But, I think without a clear articulation of the economic benefit of tackling these diseases, we're limited, inherently limited in our ability to mobilize resources for these programs, especially when, as has been said by our colleagues from Ghana, when difficult trade-offs need to be made by those who are considering the optimal allocation of scarce resources. So whether we're talking to a philanthropist or to a Ministry of Finance or Planning, I think the case for allocating more resources to NTD programs, or indeed any program, will always be made stronger if we can go beyond simply talking about the traditional sense of impact, although that's critically important around the health and well-being of families and communities, and to complement that by articulating the economic returns on these investments. So, I mean, in terms of the usefulness then in these kinds of tools, I've been reflecting on a fantastic piece of work that was actually done several years ago by Erasmus University that calculated economic benefits of achieving 2020 NTD targets. Now, of course, that's out of date by now, but the simplicity of the tool that was developed, the fact that really not that much existed at that time in this area has inspired the End Fund since to commission research that has calculated the economic impact of reaching more country and disease-specific targets. These have been tactics we have used to speak specifically to donor priorities, and we found them to be very helpful. I think, in particular in incentivizing philanthropists to continue to invest more and more. A great example was about 1.5 years ago when Niger announced its incredible progress against river blindness, for example. We commissioned research to ask the question, well, what if contributions that these sort of programmatic milestones, what contributions have they made to Niger's economy? And what might this mean for neighboring countries whose own river blindness elimination efforts are following? And this has helped us to engage with and to mobilize more philanthropic resources, as well as quite rightly celebrate Niger's achievement in that regard. But I think we've also seen national governments mobilize around these economic impact assessments. It's tremendously encouraging to hear the positive feedback from our colleague from Ghana. And in Nigeria, actually, recently on World NTD Day earlier this year, we saw the Nigerian National Ministry of Health launched 2 documents hand in hand. The first was their new national NTD master plan. And the second was a similar piece of research that we commissioned from Deloitte in Nigeria that calculated that if Nigeria's 2030 NTD goals are met in total, its economy will realize almost $19 billion worth of productivity gains that it wouldn't otherwise. And so to see the government introduce these 2 topics, these 2 documents in tandem and inherently link them as part of the same conversation has been very, very encouraging. I think so these examples, among many others, they give a good indication of the desire, the opportunity to improve country-specific investment cases. And I'll echo a few things that I've heard by others so far today. I think if we can do this in systematic ways, that's one of the biggest value adds of a tool like this, that are made easier for champions within government systems especially, and through tools that allow for interesting and comparative analysis, either across countries or maybe even between different districts or regions within a country, then I think this will be hugely valuable, and it's why tools like those we're discussing today are going to be increasingly important, particularly for domestic resource mobilization efforts. And I think looking forward, putting this into practice, once it's developed its next iteration in quite different settings, is going to be crucial to further improvements for a tool like this. For example, we've been working with 4 county governments in Kenya within the decentralized system there for a few years now on mobilizing county level government budget allocations for NTD programs specifically. And this has been a highly context specific endeavor, and the tools that have been developed to make these cases to decision makers at the county level have actually been quite bespoke. And so I think as we look about how to best improve and introduce these tools that we're talking about today, then we need to learn more about how it can complement existing dialogues within ministries of health and finance, and critically think about what training is required as well to optimize its usage within the context of national planning processes. And I think maybe just the last point I would make is that, in terms of encouraging optimal use and the optimal impact of the data coming out of tools like this, it's really important to consider what other tools and other processes are being considered by the same decision makers who we're targeting with this tool. A great example, we're seeing more and more NTD scorecards developed by our partners at the African Leaders Malaria Alliance, ALMA. Now, we know that these can be an incredibly powerful tool in generating political accountability, transparency, and commitments as well. And so, I think it's very important for us to consider how we use the investment case tools and the data they generate in a way that will synchronize with these other dialogues around political commitment. Thank you.
Thank you. Thank you very much, Sam. You actually answered one of the questions that I wanted to ask as a follow-up questions on the future development of the tool. And I had promised to go back to Brian with the same question, but I've been told that we have run out of time. And just based on the 3 interventions from the panelists, I'm sure we've managed to get a snippet of where we've come with the tool, what needs to happen with the tool, and shared experiences on how investment cases can be used, not just to mobilize resources, but also to look at the benefits of intervention and maybe the costs of not intervening. So with that, unfortunately, we have to move on to the next session, and I hand you back to my colleague Xiaoshang, and I thank you very much all the panelists for the interesting interventions. Thank you. Over to you, Xiaoshang.
Thank you, Isaac, and thank you to all panelists for your great interventions. And we learned a lot from your thoughts. There are a lot of questions in the chat and in the Q&A, and we are trying to answer them gradually. I think we are already 10 minutes to the end of the webinar. We will just maybe ask several questions, not many, and just to give the floor some oral discussion possible. Before I read the questions, I just want to know if anyone wants to ask your questions directly. Is there any hand in the room? Okay, so maybe one question that was asked was about the time between Rachel, maybe it's for you, what's the time between the intervention and the impact estimate? When you estimate the impact and estimate the cost, what's the time between the impact and the intervention when intervention happen in this tool? How you consider the time between the two?
Yes, I think that the time from when the intervention has effect, I think is the question. When do we consider the intervention has an effect?
Yeah, the question is when between the cost, the intervention happened, there is a cost, and then we will get the impact. So what's the time frame between the impact, we get the impact, and the moment we invest in the intervention? That's time frame. I think you use different time frames, right?
Well, I'll invite my colleague Yemi to come in on this to add, but we have that all in the first year, the year that we start the analysis. So the costs happen in that initial year, and the impact happens also right away. I mean, assuming that that if it's camps, if it's contact tracing, of course, there's some time, but it's all happening from the first year of the tool. Yemi, if you need to add anything or correct me, please feel free to jump in.
Yeah. Hi, everyone. That's exactly right, Rachel. So it depends on the intervention, but once the cost starts in the baseline 2019, the effect takes on. So.
Thanks. Another question is about the impact model, disease model as well. They said there are many other disease models existing already. So what's the link between the impact model used in this tool and other existing impact models or disease models?
There is no link. This is each of the individual 3 NTDs in this model are analyzed separately and individually. So yes, I think my earlier comment in response to a question from Isaac did agree that having a more integrated approach would be very desirable, not just with other NTDs where there are some impacts across some of these, but more broadly in a more full UHC approach. But there really is very little evidence for the most part about how these diseases influence each other, how the prevalence of one influences the other. Not always true, but generally true. I can just say for in NCDs where I know the models and the diseases very well, obviously diabetes and heart disease, there are very strong interrelations, and we have some evidence about that and what interventions can be used to address both of them. That we don't have that, we haven't found it for the NTDs, the three that we looked at, but it should be modeled if the evidence is there.
Thanks. Maybe a relevant question, follow-up question is how expansible this tool. There are many questions about whether we can use it for other diseases that are not currently included in this prototype, whether we can use this in other countries for pilot, whether we can add other aspects like innovation or other vector control, this kind of broader measure area. So what do you think about the expansion of the tool in general?
Yeah, in general, I think that's absolutely where the tool needs to go, is that there should be other diseases added, because some countries don't have these three diseases or they aren't priorities. And so obviously this wouldn't be useful to them as it stands right now. So it was just a pilot. There should be other diseases, and that's what the WHO Road Map of course includes, and then other interventions, including technologies. We looked very carefully at what new technologies we might be able to include for the diseases that we have. And there are a lot of technologies in the pipeline. So as soon as there is some good information about how those technologies could be implemented in country, costs are potentially available, but the effectiveness of them so far was not as far along as we felt was needed to include at this stage, but we think could be included in the future stage and would be somewhat, prospective, somewhat speculative, but perhaps important for countries to be able to evaluate whether they would want to introduce these new technologies. So that definitely could be done.
Thank you very much. I think we are very close to the end of the meeting. So maybe I'll just invite Judith and Dudley and myself. I will also share my thoughts, just to say one takeaway from this meeting. Dudley, you want to begin?
Sure. Thanks. It was really rich discussion, and I think we've set a lot of scope for future work together. Two quotes I think really sum up the approach really well. Brian's mentioned the value of this being subject to the creativity applied is really important. This will be what we make of it. With the investment cases, we mean for them to be to move the needle politically, not necessarily getting into the budget specifics and which intervention planning, but just to open the door for greater investment on NTDs broadly in each country. And the second one, Sam said, just to use this to make it easy for champions. We know that there are people in countries, in parliament, in other sectors and ministries who will take up the mantle and push things forward and create political space for us. And we need to give them the tools and make it easy to do so. But really rich discussion, and appreciate being part of it. Thanks.
Thank you, Dudley. Judith?
No, thanking also Judith Rios from UNDP Health Team and one of the focal points of Uniting Efforts for Innovation, Access and Delivery. So really thanking all the participants and RTI and the Minister of Health of Ghana for all the work done until now. I just want to really appreciate all the input received. This, as you all know, is a prototype. We're in phase one. We are testing the concept. Are we asking the right questions? Are we looking at the right data? Is this tool that's currently designed fit for purpose? And I think the feedback that we're receiving is that, yes, it is a needed tool that countries and partners need in national investment cases. And that, of course, as a prototype, there's always room for improvement and more work to be done. We're also hearing the interest on piloting and expansion to other diseases. I think that's why we had a consultation, and that's why we want to have an ongoing dialogue with all of you, is to ensure that the prototype is validated, is useful. Our goal is to expand the tool to other diseases and to use it in other countries, pilot in other countries, and then design it in a way that is going to be self-sufficient for countries to use. And we don't want to create a tool that is going to be dependent on piloting forever. We want to develop a tool that is country-driven, fit for purpose, user-friendly, and impactful, and that builds on existing data and existing tools that all of you are already developing and using, and that adds value. I think we're very close, and I think we're hearing your input. As you all know, and we said in the chat, you're going to receive a survey. This is the beginning of the conversation with us in terms of input. You're going to receive a survey where we're going to ask you for specific questions. We're also very open to discuss not only changes in the toolkit, but also and in the current prototype, but also potential next steps, including should we start by adding new diseases? Should we first test it in countries? What is the next step that makes more sense for the NTD community and for health financing experts? So we're basically trying to do this with you. We're trying not to move along individually. We're trying to move in partnership and collaboration with the NTD community and the health financing community to ensure that this is helpful to all of you. So thank you from our side, from Uniting Efforts for Innovation, Access and Delivery and UNDP. And we look forward to continue the conversation.
Yeah, thank you very much, Judith. I think that's all is a wonderful closing remark already. So I just want to mention one takeaway that I have is that the next step, we should work more on integration and standardization of these tools so that it can be easier expand to other diseases and include more interventions and also link with the national health system financing. Okay, Rachel, do you have any last comments before we close?
Just a thank you to all the people who attended, and please do keep sharing your thoughts, ideas, and suggestions, because there are a lot of different directions this could go, but we really need to know what is the most important and useful direction for you. Thank you.
Thank you very much. Dr. Sose, I'll leave you to close the session, maybe.
No, thank you so much. I think it was extremely useful, and I fully agree with the next step. We just defined it. I just put my video on to say bye to everybody. Thank you so much.
Okay,
and making
thank
sure
you
that
very
this
much.
is linked to the overall costing of the roadmap will be really critical for. Thank you.
Thank you very much, Dr. Sose, and thank you everyone participated to this webinar. We learned a lot from you, and keep in touch. We are a community, and we work together on this piece. Thank you.
Bye-bye.
Alex.